So next I'm going to talk about carbon monoxide poisoning. Just since I'm already on the topic of dyshemoglobinemias, because it's often tested. So carbon monoxide is an odorless, tasteless, non-irritating gas. Smoke inhalation is usually the main culprit. So the typical scenario is a gentleman who was in his car in the garage, decided to keep the garage door closed, and turned on the car and was trying to commit suicide, and all the fumes coming from the car were being smelled by him, and his carbon monoxide levels went up. Carbon monoxide binds to hemoglobin with an incredible affinity. It's about 200 times as strong compared to oxygen. And when it does that, the hemoglobin has a decreased ability for oxygen to bind to it, and it also makes it harder for any oxygen that's already on the hemoglobin to be released. Therefore, there's what we call increased affinity or left shift of the hemoglobin curve that I described in the previous slide. Carboxyhemoglobin also decreases the peripheral utilization of oxygen in the mitochondria. Symptoms include headache, malaise, nausea, confusion, chest pain. You can imagine if the coronary vessels cannot obtain oxygen, you're going to essentially get an MI. The traditional wording that you see in the USMLE is called this cherry red lips. Okay. What is the treatment for this? The treatment is high flow oxygen, hyperbaric oxygen, and isocapnic hyperpnea. So when you increase the oxygen, it makes it easier to displace that carbon monoxide. Hyperbaric oxygen, you have oxygen under a lot of pressure, so it pushes that carbon monoxide off. And then they have this new thing called isocapnic hyperpnea, which is essentially the concept is if you increase your minute ventilation, you breathe faster, you'll essentially be able to breathe faster with oxygen, you'll be able to get that CO2 off, but you get that carbon monoxide off. The problem is that then you would develop significant respiratory alkalosis. So what isocapnic hyperpnea means is you hyperventilate a patient, but at the same time you're giving them CO2. Okay, so you're giving them CO2 to maintain normal CO2 isocapnia while producing hyperpnea. So what are some clinical pearls? Again, in this one, SpO2, your peripheral pulse ox will be inaccurate. It'll actually be reading very, very high, 98, 99, 100%, and it has to do with the fact that carboxyhemoglobin absorbs light similarly at the same wavelength as oxyhemoglobin. So it measures it, your pulse ox will read a very high SpO2. Your PaO2, your oxygen tension will be normal. Again, just like methemoglobinemia, you will have a normal PaO2 because you'll have a certain tension of dissolved oxygen in the blood. Your SaO2 will also turn out to be normal because the SaO2 in a non-co-oximeter calculates an ABG, calculates, like I said before, the PaO2, and based on the PaO2, you end up developing, it ends up telling you what your SaO2 should be based on that PaO2 hemoglobin curve.
Like this video and smash that subscribe button as well, and make sure that you hit the bell button and get the notifications for the new videos in the future.